You do not need to diagnose a skin spot at home. You need to recognize when the pattern has changed enough to deserve a professional look.
This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist.
But hold on a second. How do I actually know if a spot has changed enough to worry? I mean, it kind of feels like almost everything on my skin changes a little bit over time, right?
Section 1. Triage, not home diagnosis.
So that is the exact friction point we're going to solve today. To start, we really have to remember that a spot or a lesion, well, it's just a description. It literally just means an area of skin that looks or feels different. It is absolutely not a diagnosis. Your goal here isn't to play doctor at home, it's simply triage. We want to protect you from two very common everyday mistakes: assuming every unusual bump is cancer, and on the flip side, assuming an ordinary-looking spot must be completely harmless. Most skin lesions are actually benign, but meaningful dynamic change, that is often your absolute most useful clue. Think of it like a giant puzzle. You're looking for the one piece that suddenly no longer matches the surrounding set. If you've got a spot that is newly growing after a long period of just doing nothing, or a surface that repeatedly bleeds, crusts, or forms an ulcer that stubbornly won't heal, that absolutely deserves attention. Pay close attention to new symptoms too. Things like pain, tenderness, or unusual firmness. And crucially, keep an eye out for the ugly duckling, a spot that just looks entirely unlike the rest of your skin's usual pattern. If you're seeing these dynamic changes, especially rapid, raised growth, the practical response is to arrange a professional evaluation, not to just repeatedly treat the surface yourself at home.
Section 2. The limits of checklists. Wait, so the ABCDE checklist isn't everything? Can I just quickly run through that list to safely clear a spot at home and save myself a whole trip to the clinic? The ABCDE checklist is an excellent memory aid for sure, but it is absolutely not a clearance test. Let's break it down really quick. It prompts us to look for asymmetry, border irregularity, color variation, and diameter, historically looking at lesions larger than 6 millimeters. But the absolute most critical letter in this whole acronym is E for evolution, meaningful change over time. ABCDE is a fantastic reminder of what to look for, but simply checking those boxes doesn't mean you're perfectly safe.
In fact, relying strictly on those classic ABCDE rules can give you a really false sense of security. See, classic melanomas are often dark, irregular, and asymmetric. But atypical melanomas can totally break all of those rules. They can be nodular, meaning raised and firm. They can be amelanotic, which just means they're pink or skin-colored and lack pigment entirely. They can be smaller than 6 millimeters, fairly symmetric, or incredibly fast-growing. This brilliantly illustrates why a simple visual checklist can totally miss dangerous changes.
Okay, that makes sense for melanoma, but what about other types of skin cancer? Do they follow the exact same ABCDE warning signs?
No, they actually have entirely different patterns. Basal cell carcinoma, or BCC, well, it might look pearly, shiny, or kind of translucent. It could even resemble a persistent eczema patch, a scar-like area, or a sore that repeatedly ulcerates and then returns. Squamous cell carcinoma, or SCC, on the other hand, often looks rough, scaly, tender, thickened, or maybe like a rapidly growing, firm crust. The critical limitation here is that these features are totally nonspecific. They heavily overlap with benign inflammation like a persistent pimple, a scar, or just an irritated patch of skin.
Section 3. When apps and photos fail. All right, let's do a quick reality check here. If my own eyes and checklists aren't enough to firmly rule out cancer, can I just snap a photo and use one of those consumer smartphone apps? I mean, the technology is getting so wildly advanced. Can't they just tell me if my spot is safe?
Let's actually look at the strongest evidence to answer that. First off, even in pooled studies of selected lesions, visual inspection checklists only hit about 83% sensitivity and 88% specificity. To put that into plain English, those tools miss cancers, and they falsely flag perfectly benign spots as dangerous. But when we look at the apps themselves, the data is honestly shocking. A Cochrane review of smartphone applications for melanoma triage showed that published app sensitivity ranged from a dismal 7% to 73%. Think about what that actually means. In the evaluated datasets, some of these tools mislabeled 27 to 93% of melanomas as low risk. That's huge. A reassuring app result should never, ever overrule a concerning, changing spot on your body. And while snapping photographs on your phone is a fantastic way to document change over time to show your doctor, a photo cannot safely clear a lesion on its own. I mean, a photo cannot feel the skin for firmness or fixation. It almost always lacks consistent scale, distance, and lighting. Plus, an app or a single photo isn't exactly examining hidden sites like your scalp, the palms of your hands, the soles of your feet, or your nail beds. They completely lack real clinical context.
Section 4. The dermatology evaluation. So, if photos and apps fail us, what exactly does a dermatologist do differently during these in-person evaluations?
A dermatologist combines several layers of context that a screen simply cannot replicate. First, they listen to the story. When did it appear? Does it bleed, hurt, or repeatedly heal and recur? Next, they look at your whole skin background pattern to hunt for that ugly duckling. Third is touch, actually feeling if a lesion is mobile, firm, or fixed deeper in the skin. Fourth, they use dermoscopy, which is a specialized optical tool. And finally, they use clinical judgment to determine the safest next action, whether that's reassurance, treatment, monitoring, or a biopsy.
And this brilliantly illustrates why that specialized tool matters so much. A Cochrane review estimated that unaided visual inspection has about a 76% sensitivity for detecting melanoma. But with trained dermoscopy, that sensitivity jumps up to about 92% at a fixed specificity of 80%. The clinician isn't just looking harder, they're accessing entirely new visual information like subsurface pigment and vascular structures, and seamlessly integrating it with your clinical context.
Section 5. Monitoring versus biopsy. All right, so after the exam, how do they actually decide the safest next step? Is it safe to just watch it, or do they immediately need to do a biopsy?
They draw a very firm, evidence-based line here. Monitoring is not just some casual, let's wait and see. Short-term dermoscopic monitoring is a highly strict clinical plan, and it generally only fits carefully selected, flat, mildly atypical moles where reproducible images can be taken and follow-up is highly reliable. On the other hand, a biopsy is usually favored for anything raised, nodular, rapidly growing, painful, or bleeding. You should absolutely not place a rapidly changing, symptomatic lesion into casual observation.
And if a definitive answer is genuinely needed to make a safe decision, a biopsy is performed. This involves removing a tiny bit of tissue so a dermatopathologist can examine the cells and architecture under a microscope. When your diagnosis or treatment plan depends on microscopic information, histopathology remains the absolute reference standard.
That makes total sense. But practically speaking, if I do notice something concerning, how urgently do I actually need to be seen? Are we talking a drop-everything emergency room visit, or can I just wait a few months?
Well, most concerning skin lesions are not emergency room problems, but they do require a timeline that accurately matches your symptoms. If you're experiencing rapid growth, spontaneous bleeding, ulceration, new pain, numbness, or you feel a firm, fixed lesion, that requires a prompt professional evaluation. Delay absolutely matters when a lesion is behaving aggressively. However, if you have a clearly evolving or ugly duckling lesion without those acute symptoms, a timely scheduled evaluation is perfectly appropriate.
The absolute crucial point I want you to take away from this explainer is this. You do not need to diagnose a spot before asking for help. You only need a good reason to look closer. Just watching it is not a neutral choice. And remember, a reassuring smartphone app result should never overrule a concerning changing spot. So the next time you spot a changing pattern on your skin, ask yourself, are you trying to diagnose it yourself, or are you just looking for a good reason to get a professional's eyes on it?
We invite you to read the complete Skin Trust article on this topic and discuss your individual decisions with your treating clinician. Remember, Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. Check out the next Skin Trust explainer to continue building your knowledge.